just the most wonderful thing for me. So I hope to share some of that passion with you. I have my colleague Marvin's name on the front of my presentation because this is the skeleton of it is something that we have delivered previously. So before we start defining simulation, before we start delving into the things that I'm very excited about, first I'd like to introduce you to Mary from Kenya.
Solomon, Joe, I can't hear Mary. She's supposed to be talking to us.
That's very sad. All right, so I will just tell you about Mary rather
than. No, look, I think try again and
try
see.
Again.
Maybe have like a volume up on your side.
I'm at full max, I'm afraid.
Oh.
So what I will do is this is the very quick intro. I will drop into the chat the full video and start talking about where Mary fits in. Mary works at a hospital in Nairobi, Kenya. She is part of a large in situ simulation program aiming to decrease maternal and neonatal deaths through simulation. They achieve this through the use of bean bags that look like pregnant tummies and babies that don't look like babies. They are just sewn dolls, and they have shown that they can decrease the maternal mortality in their hospital by significant amounts. Mary is joined in an equivalent program in rural Tanzania, where nurse educators provide healthcare workers with practice sim dolls, which gives them automatic feedback, and they have used that to decrease newborn mortality by 50% in 3 years through the use of self-directed learning using a simulated using a baby which has a simulated heartbeat, and I'm just going to mute you, and they can have improved the recognition and resuscitation of sick newborns. They took their mortality down from somewhere in the 80s down to below 30% in 3 years. So the question that I would like to ask you as a whole is, sorry, I haven't spelled, is why do we simulate? Can anyone share with me where they've seen simulation used in their setting before? This Tombo was talking about maybe using it for assessment. Why have you seen simulation used before?
If I can answer from from the orthopedic side, so we use lots of implants in our daily trade, and often when a new implant comes out, they, especially nowadays, they've got this virtual reality that you put on the goggles, and you can do the or at least put together the new implant and all the sets that it comes with. So you do it in that virtual space until you're familiar with the components of the implant. So yeah. It's really just virtual reality. Yeah.
So you're using it to learn a new skill. Yes. And the evidence shows us that if we teach skills through simulation, your learning curve is so much steeper, and the learning curve from no knowledge to proficiency and safe practice is much steeper with the use of simulation. Has anyone else seen simulation used in their setting?
Delphine here. Hi. I've seen it used when I was working in Switzerland a lot. It was part of our training in emergency department and in the PQ, and also then they move things to the ward, and it was always to address like a clinical problem and communication problem within the team. And then we've used also, I've used this once when I was in Cape Town to test massive transfusion protocol activation in theatre.
Oh, so you've had some wonderful exposure. So anesthesia they were the kind of founders of using simulation for clinical improvement. So clinical improvement's a big area of why we use simulation. And I'm so glad you said communication, because teamwork, communication, and leadership are kind of the secret sauce of where simulation really can make a difference. And the big area of progression in simulation research these days is around systems testing. And there's lots of great articles about simulation to test new systems, simulations to test new facilities. And a personal example was when we started using when we were starting up the ECMO retrieval program from Proficiency, the idea was that the surgical team and anesthesia team would go to the referring hospital, initiate ECMO and retrieve the patient on ECMO. And it was only through actually physically doing this with a mannequin on a simulated ECMO retrieval that we realized that some of the routes down to Proficiency were steep enough and bumpy enough to actually affect the functioning of the ECMO machine. And so we've rerouted the way that we move patients towards the hospital just because of that. Also lots of conversations about how we fit ECMO into a CT scan. So I think that really describes it beautifully. We use ECMO for we use simulation for clinical improvement. We use it for teamwork and communication, and we use it largely for systems testing. And I think that the thing that we are not yet concentrating on in our setting in particular, and a lot of simulation literature comes from high-income settings, but I think the other area that we need to explore in simulation is its role in transformation. The purpose of simulation is to have an experience that is pre-planned and facilitated, and then to debrief and talk about it. And I really think that in the we talk a lot about problems with hierarchies, challenges with getting teams to function better together, and communication. And when you go into that debrief space, that facilitated conversation, that's really, really where the magic happens, and where we're able to bring together what is hidden, whether they are power dynamics, hierarchies, or related to clinical care aspects that we're not aware of. So the thing that I'm going to challenge is, what is simulation? So the quote that we use is, simulation is a lot of things, but simulation is not everything. So simulation has developed so hugely that it's moved from just the idea of a simulated mannequin with some people learning around it to simulated patients, so paid actors who come into learning spaces and conduct scenarios which may be mental health scenarios, they may be history taking, and it's a really amazing and effective teaching methodology. It takes a lot of the risk away from the clinical platform and a lot of the onus off our clinicians who are struggling to teach and perform their duties. So that's simulated patients. We then also have a range of what we call fidelity. So fidelity is a kind of a word that we've dropped out of our simulation wording, but what we're looking for here is realism, so or technology. So what do you see quite often is people buying the most expensive mannequin that they can find. At my previous job, I had a 1.5 million rand mannequin that had full ultrasound capabilities, walked, talked. He didn't walk, but he talked, he breathed, you could listen to his heart, his lungs, his abdomen. And you know what? We really didn't use him nearly as much as we used the 150,000 rand mannequin with much better, and we used a different kind of monitor interface. So I think that the point is, with simulation, money is not everything. Technology does not affect the quality of your simulation. So low technology simulations are just as effective. And in fact, we have colleagues in the Eastern Cape in the emergency medicine departments who teach birthing emergencies using a teddy bear and a cardboard box, and it's highly, highly effective. So those are the kind of traditional simulations we know, the mannequin-based clinical simulations. And these can be conducted in simulation labs, or we can conduct them in situ. In situ means that we are in a clinical space, in a space of clinical work, and that comes with some risks, including contamination of the clinical. Someone, please don't mute me. Someone was, you don't want to contaminate the clinical space with things like expired drugs, etc. But it is an enhanced way of learning, learning within the clinical space. Great. So does that change your understanding of simulation? Does anyone have any other forms of simulation that they have experienced that they would like to share? Welcome to all those who have joined us. All right, so I'm going to talk quickly about a few core concepts in simulation that I think make it very special. So this is called the basic assumption that we're going to start off with. The basic assumption is a way of framing the pre-brief that makes people feel more included and safe. So we start a simulation by saying the following. We believe that everyone participating today is intelligent, capable, cares about doing their best, and wants to improve. And these are the kind of fundamental principles that make simulation an effective education modality. People have to feel included and heard in the space in order to best benefit. We also stick by and advocate for the principles of justice, equity, diversity, inclusivity. And we are aware that we have unconscious or implicit biases that may subconsciously affect the way that we interact with those around us. Now, that's important because when we are in a space such as ours, South Africa is full of unconscious and implicit biases, and it comes out in the debrief. And so simulation educators have to be very careful about their design, very careful about the way that they steer both the scenario as well as the debrief. And then another fundamental principle would be debriefing with good judgment. So I'm not going to go through these, but the idea would be that we are here to be curious and to ask questions. And I think that one of the real joys of simulation, and one of the things that has given me as a clinician, is this ability to be curious. So as an example, we may have a registrar who comes into a scenario and they consistently give the wrong drug dose through the scenario. So instead of coming into the scenario and asking them questions about, why did you do, this is the dose, why did you give that? If you phrase your questions in a way that invites participation and say, I noticed that the drug dose you gave was, 0.5 milligram of adrenaline. We were in cardiac arrest. My understanding is that the dose is 1 milligram. Can you explain to me where you learned that dose or what protocol you were following? What often comes out is, well, my consultant was standing there and he's told me previously that that's the dose, and I've tried to show him the evidence. So I think that it's a really beautiful way of changing the way that we communicate, not only in medicine, but also in our day-to-day interactions, that we assume that someone is trying their best and that we're curious about what actions they've displayed. Okay, great. So now I'm going to talk about the common pitfalls that people encounter when they start in simulation. So it's important that you have an understanding of educational methodology. And often what we find is the simulation can be harmful. So I'm a paramedic by background, and I can tell you that simulation in my undergraduate training was harmful because it was not a learning experience. It was definitely about being embarrassed or being shown up for not knowing what you were supposed to know. There's also a lot of design that goes into simulated scenarios. And so I encourage you, if you're thinking of venturing in this direction, to get some training beforehand. And that educational methodology ties in with a program. So the idea behind joining a program and not starting your own is that if you are without a program, you're going to end up really quite lost and feeling like you're not achieving very much. So programs consist not only of design, but also of evaluation. And that's why we call it a program, not just a simulation event. So let's dive a little bit more into what is available. So on the one side here, you can see some interns practicing basic airway maneuvers. And that is an inexpensive mannequin. It's not something that you would have to get large amounts of funding from your hospital for. It's a robust mannequin and very effective for teaching basic airway maneuvers. Now on the right, you can see the COVID airway team practicing their intubation skills on the same mannequin. And I think this is a beautiful illustration of how we put a lot of time and effort into perceiving simulation as needing to be high energy and high fidelity or reality or technology. But the reality of the experience is that it's about how they interface with that space. So these registrars are here intubating in a simulated COVID ward area for the first time in their full PPE with the COVID trolley with minimal equipment. And so the stress levels are very high. And the realism and the edge of which they are performing is definitely a right at the edge of where they should be and how they should be learning. These are some of the registrar sims that we run. So this is our very high fidelity mannequin. He's has pulses. You can auscultate his stomach, his lungs, his heart. He talks, blinks, and has seizures. And we use him for the majority of our work. So this is more useful for us as we teach a lot of critical care simulation. But if I'm honest, I'm not sure that the feeling of a pulse on this mannequin correlates to the feeling of a pulse on a real patient. And so sometimes we do have discussions about what it is that fidelity does lend a student. I'll give you an example here. So this is an anesthetic registrar cardiothoracic simulation. This is part of the program that they go through just before they write their part twos and leave our program. And we put we have MacGyvered the mannequin to be able to use the chest drain. And so as the mannequin breathes, so the chest drain bubbles. And this is part of the realism of the scenario of a patient who has a tension pneumothoraces. It is so uncommon because of the stress of the environment. It's so uncommon for the registrars to notice the functional chest drain first up that we have actually started introducing it in the briefing of the scenario so that they're aware of it and they use it as part of their clinical information gathering. But it's, so if you're worried that a low technology simulation is going to be not stressful enough to teach with, simulation in itself is inherently stressful. You're performing often in front of peers, and there's been some lovely research done in South Africa with a cortisol swab on the inside of the cheek of people participating in simulations and people watching said simulations, and they could show that stress levels are matched. And then I'd love to talk about simulation for clinical healthcare, for clinical quality improvement. So in 2015, the critical care unit at Curtis Care reached out to Project Team Care, which is a quality improvement initiative based in the Department of Anesthesia and Perioperative Medicine. And they said, we have a big problem. We have a trachea patient having a serious adverse event or dying every 6 to 8 weeks in our unit. And we have rotational registrars. We're really struggling to change this. And so Project Team Care went in, and every week they ran a tracheostomy emergency simulation. And within a few weeks to months of starting to run those sims, the tracheostomy adverse event and death rate dropped to almost 0 and stayed like that for close on 3 years. Unfortunately, during the pandemic, it was not possible to run these in situ simulations every week anymore. And as a result, the pre-COVID adverse event and death rate climbed over 2.5 years to back to the rate that it was at before we started running the simulations. And we have started again now, and we can again see the numbers improving. So a great example of a clinical initiative and how simulation can solve a clinical need, but also the importance of measurement and matching your educational improvements with a pre-planned measurement. And then this is our ICU simulation. So we run a weekly ICU simulation in the critical care unit. We have a cubicle in one of the ICUs at Proficiency, and we run a series of sims. And these sims are all informed by our answering the question, how do we help rotating registrars who may not have any emergency medicine or critical care exposure for many years before joining a 3-month critical care rotation? How do we prepare them better for their time there? So we run a range of simulations. And what's been very interesting is, although we're not measuring it clinically yet, the feedback from each of them is, I feel less anxious. And I think one of the beauties of simulation, and one of the things that's very worth talking about, is how do we match our clinical outputs, our clinical measurements, with measurements of human factors. So human factors of simulation and medical care are what affect patients' outcomes. And so simulation is a great place to stress you to the edge of your competency, but it's also a great place to prepare you and inoculate you for the stress that is coming. So one of the most important aspects of our work is faculty development. And while I'm hopefully inspiring you to get into some simulation education yourself, the question that I'm often asked is like, where do you start? Where do you start? Well, I'll talk about some courses in a moment, but the foundational training that you require is some educational theory, as mentioned previously. But basically, if you would like to start simulation, join a program near you and get some good exposure, so that it's very much a scaffolding process. You need something to start scaffolding your learning on through self-reflection and peer feedback. And as you grow, you can explore different modalities of simulation and different places to run it and different complexity, and go from your discovery to your growth to your maturity phases. So what are we doing at the University of Cape Town to answer these two, this conundrum of expanding simulation? So Africa is known as a simulation naive context. It's a very lonely place to start out if you'd like to start simulation. So we're doing two things. We're running a 2-day course called a Simulation Launchpad course through the University of Cape Town. But most importantly, and I think a lot more impactful, is we launched in June this year the African Simulation Network. The African Simulation Network is in its infancy, and I will drop you an email with some links to some videos that are worth watching about what programs in other countries look like. But I think that the thing that I'm hoping that the network will bring is an empowerment. I hope that people take this opportunity to really grapple with what simulation is and what it can afford our context in particular. I think that it's a wonderful medium for addressing transformation in medicine, not only in terms of hierarchies, but also in terms of how we perceive and communicate with those around us. And so I'm going to end with a little tip for if you were thinking of getting started, or if you're thinking of starting a program where you are. One is to start simple. There is a lot out there that you can get your hands on to start a program that you are looking at. Simulation in surgery is used very, very widely. And instead of buying a large, expensive mannequin or simulator, start with some simple scenarios, start to feel out the process, and explore products like, there are laparoscopic simulators that cost upwards of R1 million, upwards of 6 million rand, but you can also purchase something called surgery in a can, which has various urological and gynecological pathologies located within a can. So either you want to practice a procedure, in which case you'll be gently shaving away foam, which looks exactly like the anatomy that you're supposed to be seeing, or you're looking for a diagnostic can, which is going to show you a variety of pathologies, which you'll be asking registrars to diagnose and then treat surgically. And I think that, you know, this is the kind of, we should be investigating African solutions to our problems. And so my beg is to not invest in large and expensive simulators first off, that there's a lot more program evaluation that needs to occur before you do that. Number two, that the gem, the real center of your program is on your faculty, and a focus on faculty development is definitely the way to start. There's a lot of obstetric, gynecological, surgical, and emergency medicine simulation happening in hospitals and universities across Africa, in undergraduate and in postgraduate programs, and for continuing medical improvements. And don't start something new. Just tap into an existing network, see what you can learn from there, and continue expanding. I'm going to ask if anyone has any questions. Or has any simulation running in their area that they're interested in expanding. So Tombo, how does this sit with your orthopedic simulation?
No, yeah, I was going to ask a question just now. So, you know, as you know, we do lots of cadaver sessions, you know, so, you know, in terms of, you know, which is more, look, of course, there is a cost component to trying to procure the cadavers. There's also an issue with availability, but in terms of outcomes, you know, certainly for like a technical skill, which one do you think, you know, is better at training or produces, you know, more desirable results, like simulation with mannequins or like a true cadaver?
So I think that it's again depending on what you're trying to do, and if you're trying to teach a skill, you need the medium that best represents the skill that you're trying to teach. Yeah. So if you're trying to teach simulation, is only as good as the medium you're using and your facilitation.
Yeah.
So for example, I understand that there's a discussion around knees occurring at the moment.
Yes.
Yeah. Okay. Yeah. So my answer to that is, I think that there you're trying to teach a skill, and as soon as you're trying to incorporate that skill into a scenario, that's where simulation will start. So if you were trying to simulate for your registrars a surgery from start to finish, that's where I think you'd be talking more about simulation. For skills teaching, I think that the cadaver obviously is the most human-like that you're going to get. Yeah. But I have no doubt that there is on the market, or that it's possible for us to create simulators that could work for you just as well. It just all depends on what you're trying to do. So in the ultrasound simulators, people use jelly with objects stuck in. So if you're trying to simulate the density of skin and muscle, there's plenty of things that can do that. If you're trying to teach the registrars how to cut and clean properly, they don't need to do that on a cadaver. They can do that on some kind of simulated space. Does that answer your question?
Yes, it does. Thank you. Thanks, Joe.
Pleasure. And then I think you brought up an important thing earlier about simulation for assessment.
Yeah.
So I think sort of looping back to the conversation around do we need simulation for assessing competency in any form of specialization? I think that it's very difficult for a few reasons. One is that your performance in a simulation is very much related to your exposure to simulation. So as an example, in anesthesia, the Gauteng registrar rotation has a very, very strong simulation practice. They do simulations 2-3 times a week. Our registrars do not get that amount of exposure, and so they would be disadvantaged if their assessment was simulation. They would be disadvantaged because you're not measuring their performance in a real environment. You're measuring their how well they can behave in a simulation. So I think that the literature supports that simulation for assessment is truly challenging.
Yeah.
It's a difficult environment to reproduce in a way that doesn't affect your performance. And as we know, human factors are a huge element of how well or badly we perform a skill.
And then just on a similar or same topic, you spoke about our knees briefly. So, we've got this thing called the Orthobox. So basically, I think Kirsty was doing her M.Med on it. So it's every new registrar that comes gets the Orthobox, and they do like arthroscopy skill in the Orthobox. So we measure the time it takes them to get the 3 rubber bands into wherever it must go. So you measure first, and then you allow them to practice, and then you measure again, the time. Of course, after they've had to practice, they are much, much quicker, which of course means that simulation improves your performance. But how much of that then translates into the actual surgical skill? Because now they can do it in the Orthobox, yes, but now when you give them like a real arthroscope in theater, how much of that competency is easy to attribute directly to the simulation?
So I'm going to speak widely because it's a little easier. So one of the things we know in medical education is that self-assessment is really problematic. So if you give the registrars a survey before the box, after practicing, after the assessment, and after their first attempt on a human, they may say, oh, it went so well, when in fact the feedback from the consultant next to them is that went so badly. And so self-assessment is a difficult form of assessment. When we look at assessing clinical skills, I think what you're asking is, does the Orthobox replicate with sufficient like motor skills the experience that you're trying to get them proficient in? And the only thing that can answer that for you is physics. So the amount of resistance that you have in your box, how quickly you're able to move things, those kind of things. So I think you'd need some very objective measures for what you're looking at. I can give you a slightly silly example of demonstrating to students how badly their stress affected their clinical performance, which is in my previous job, I designed a helicopter simulator. So it looked and felt exactly like the inside of a helicopter. And I would always start our simulation days with strapping everyone into their seats, headsets on, loud noises, helicopter noises playing, and then 10 seconds into the sim, the patient would stop breathing, and their only job was to reassemble a BVM. And the time started when the students, when the patient stopped breathing, and it ended as soon as they had put the mask, fully assembled BVM onto the patient's face. So there we used time as a measure, and it was a very effective measure because it really demonstrated to them that the stress really affected their performance. So I think in your situation, we would need to look for some established in the literature metrics for what is proficient. But again, there is a network of simulation surgical research which is occurring across the world, and in fact, perhaps one of your biggest allies would be the Ugandan orthopedic surgeons who are busy setting up what sounds like a very comprehensive surgical sim program, aiming to get students up to enough skills exposure to be able to start getting some more exposure in theatre.
Yeah.
So what's very exciting about this and why this is a well-timed presentation is that the University of Cape Town and the as a whole, the Division of Surgery under the leadership of Graham and Daniel Nell are moving towards incorporating simulation more widely across the whole surgical platform. So the obstetricians are leading the way. They've bought a laparoscopic trainer, which will be located in the clinical skills lab within the next 6 months. And I think that there's a lot of shared energy there, where there's lots of sharing and excitement around the use of simulation.
Okay. No, thank you. Thanks, Joe.
Does anyone else have any experiences or questions?
Just I think that teaches you.
Actually, I'm struggling to hear you a bit.
I think my connection is quite.
I'm struggling to hear you.
I think it's my connection. Let me try to sort out my connection.
It's much better now.
Is it better now?
Yeah.
So I was saying with the Orthobox, there's what Sitombo was talking about now. There's certain things that it teaches you, and this has been shown. Although it does not simulate actual human joint, but it teaches the registrars or it teaches the trainees to be able to what we call triangulation, to know where they're in space, where their hands are in space, which is a very important skill to have when you're doing arthroscopy. And also to work with your face, with your eyes stuck on the screen instead of looking at the patient, which we are used to working with open surgery, looking directly at the wound. Whereas with arthroscopic surgery, you need to look away from the patient and look at the screen. So in terms of simulation, yes, I think the cadaver is important, but I think you can start with a virtual simulation. You can reset it. That's a good thing about it. You can do it as many times as you can. The cadaver simulation tends to be a bit limited on resources. If you mess it up, you cannot redo it. It's messed up. It means you must get a new cadaver. So I think it's important to get virtual simulation first and get used to the virtual simulation first, and maybe you can move to the cadaver simulation afterwards.
Absolutely. And I think, if we're talking about skills proficiency, which is what we're trying to build through surgical training, you're moving them faster along that curve in a multimodal way. So they get the Orthobox first, they get some spatial awareness and some ideas of how to use the tools, and then they move up another level of difficulty into the cadavers, and they can continue to challenge their skills and decision making on patients themselves. And I think that the point is around patient safety as well, not only training, is that if we take a step back from how we used to train, which is you used to learn like on the job, what's the saying is see one, do one, teach one is the polite version. It's like see one, mess one up, try it again, maybe teach someone is the reality of it. So I think it's a valuable way of viewing it, is that we're scaffolding towards better patient safety and accelerated learning and uptake of skills. All right, anyone else? Anyone else got a question or would like to comment or talk about their program? Okay, well, yeah, Ivan, you don't have to put your hand up, just chat.
Hello, So yeah, it's just a comment, and actually, I think it was in last year I had the pleasure to assist Dr. Essine, who is a neurosurgeon from Cameroon, and he was moving from town to town, from medical schools to medical school with the tools from Obsurgeon. They have some neurosurgical kind of neurosurgical simulation tools where you can have some like parts of the brain, and that really helps you to better teach anatomy. And what we observe is that most of the students that I mean, from the medical schools in which we were, where we went with the tools, the feedback was really impressive, because most of those students had never seen a brain in real life, because of course, yeah, of course, neurosurgery is not very well developed in some medical schools in Cameroon, and to be able to see those equipment, the equipment we had from Obsurgeon, and to touch the brain, to like, I mean, it's true there were some kind of like in French this is called maquette. I don't know the word in English. Yeah, to be able to touch those structures and the instruments we had, it actually gives the student the impression they were touching the brain, and it was the first time they had such experience. And we also observed that it was far more easier to teach anatomy using those instruments, because they unlike what Prof said, like due to cadaver dissection, there's a lot of bureaucracy. I mean, a lot of work that goes around preparing a cadaver and making sure that the cadaver is of good quality to be able to do the dissection. But with this instrument, they're always available. You just need to buy them, and yeah, it really facilitates work. So it was really impressive to assist with that, and that I really think it's a good way of not only teaching anatomy but also like some basic surgical procedures, and it was really impressive.
It sounds like what that professor did for you was really, bring neurosurgery to life for students. That sounds like a magnificent use of the craft. I think it's another illustration as well of, in previous generations, they learned on patience. We're learning faster and probably better without having to crowd theatres and affect surgical performance. And I think that's a really lovely illustration of how we can encourage people to find joy in learning through exposure. Thank you for that example, Ivan. I've dropped into the comments a link to the video that I was trying to show you. This is the longer version. It's Mary from Kijabi Hospital in Nairobi talking about their experience of in situ simulation and how well it's affected their maternal mortality and outcomes. And then I'm just going to I'm going to read you Priyanka's question, which is in the chat. Hi, Priyanka. She says, if anyone has experience in evaluating simulation, are there any evaluation tools? We use a cleft surgery mannequin. And the evaluation tools we have don't show translation of simulation practice into competency. So Priyanka, I think that the answer to your question is that you would need a multi-layered assessment tool. So if you consider how we measure competency over time, you can't just measure it at the time of procedure. You would need to measure it over time, which sounds like what you're trying to do. Perhaps your difficulty there is not with your evaluation tool. Sorry, I don't want to speak out of turn here. It may be related to your educational design if you're struggling with how it translates into competency, and perhaps we can have a conversation about it and you can tell me a little more instead of me blindly commenting on it. But evaluation tools in simulation are in clinical environments often related to adverse events, and I think that what you're picking up on there and the reason that we have a lot of people looking into how do we evaluate proficiency in surgery is that the medical education literature doesn't really have an answer for you. So what does proficiency in certain skills look like is a big and unanswered question across a lot of surgery. So there's someone at UCT who is looking at how do we better assess surgical proficiency? And he is part of a network of people answering that question across the world. I hope that answers your question. You can drop me an email or drop a comment if I haven't quite answered it. Thank you for your question. Does anyone else have a comment or an experience they'd like to share? Otherwise, I will give you a hard pitch. Okay, so I'm not seeing any burning questions, and so I'm going to close today's meeting with a bit of a pitch, which is one of the things I think that we don't realize as clinicians is that we're not only clinicians, we're always educators. And I don't believe often that a lot of our training gives us the skills and theoretical knowledge that we need to be better clinicians and teachers, and how we teach affects the generation that comes of clinicians that comes after us. I really believe that simulation education and the debriefing tools that we use made me a better clinician, because I am no longer, I'm a lot more curious, and I know that sounds like an odd thing to say, but it really, really works. If any of you are interested in simulation, please feel free to email me. The African Simulation Network runs through UCT a variety of simulation-based courses where we can teach you how to deliver and measure your simulations. If there are no further questions, I'm going to wish you all a wonderful weekend.
Cool. Thank you. Have a nice one yourself, Joe. Bye-bye. Thanks.
Bye, everyone.
Thank you. Goodbye.